talk today is about somatic dysfunctions, what it means in terms of psychosomatic osteopathy. And for me it's important, I will talk as a clinician, not as a researcher. So my patterning in my daily life is completely different from a researcher. The researcher tries to isolate confounders. This is my daily challenge to deal with. And if, for example, a researcher tries to isolate placebo effects, I use as many as I can. Sometimes I have a feeling I use more than other things in my clinic. And it's totally okay for me. So my patterning, my daily life is completely different. I have to deal with chaos. I have to deal with reading every time again individual patterns, clinical patterns of the patient, and somehow come out with a kind of what we could call therapeutic approach. And said this, first of all, when I started osteopathy, I learned, and I think you too, a lot of tissue dynamics, how to palpate it, how to name it, bring it in context to capacity of the body, perhaps for co-regulation in relation to postural behavior, to body physiology, and deal with it in many different ways, structure, functional mixtures, energetics approaches, perhaps also intuitive approaches. And in 2006 I integrated more morphodynamics, so how the ontogenetic dynamics influence perhaps also when we confront with clinical patterns in the patient. There came out 2 books of it. And this means, for example, that in early time in life we have dynamics which could give us a better understanding when patient comes to us in our clinic nowadays. For example, the heart-liver-brain triangle, it's cool perhaps to understand and to know that the development of the heart is firstly inhibited by the notochord and by the ectoderm, and it is basically the liver again. And it's basically the heart who, by secretion of fibroblast growth factor 1 and 2, stimulates the endoderm to develop liver, and what we call liver. And later on, also too, that liver produces the blood for the heart. But later on also the brain-liver ratio is really important. If it's too big, then even the child could be dying before it is born, because the humans has the most high resting metabolism. Why? Because of this thing here, which needs a lot of blood, 22.5% of our blood, only for 1,360 cubic centimeters. It's extreme, no? And later on also it changed. If we will develop fatty liver, then the brain contains more fluids and the brain mass shrinks. And it's clinically relevant. 1/3 of us in Germany have already findings of fatty liver. So it is clinically really important to understand this kind of dynamics, also clinically. And of course it has meaning perhaps for our palpation. I will not go to it in terms of the central nervous system, in terms of the formation of the blood, and the heart specifically, and the liver. But it's not the talk of today. It is also not the talk too much of anatomy and research. Basically, I want to present you how over the time my clinical reading patterns change because of challenges in my clinical daily life. Yeah, so this was only one thing, but then I was confronted with other clinical challenges. And I give you one example of one top-down process. Yeah, still was not able to understand that there are hierarchical procedures and dynamics in the body based on evolutionary and ontogenetic dynamics. Yeah, for example, just as an example, one top-down dynamic. For whatever reason, let's say that in our prefrontal cortex we got the belief that the world is not safe. Yeah? So when I come now here, stand in front of you, my mantra deep in my unconscious, sometimes also in my conscious comes that the world is not safe. You know? It top down a little bit. You know, the prefrontal cortex is only 6 million years old, so it's not, it's quite young for a whole evolution of the Earth, 4.56 billions of years. Yeah, and then limbic system, a little bit newer, 165 million years old, a little bit less flexible, one neuron, about perhaps 5,000, 4,000 synapses. Yeah, but what would this trigger if I have always this nice mantra in my head, the world is not safe? I look in your faces, oh no, you are not safe. Yeah? So, of course, it triggers perhaps with a slightly higher risk emotion like fear. Okay, and if I have this fear and the world is not safe all the time coming, running through me, bodily, mindly, of course it triggers also in our brainstem, much, much older, 500 million years old. Yeah? Here the older is more fundamental, the newer is more meaningful in a way. We will see it later what it means clinically also. Of course, it heightens also the risk to trigger certain states and activity of the ANS, like sympathetic regulations, more like alertness, sensation of vigilance, and if I have all the time this mantra in my head, the world is not safe, wherever I look, and getting a feeling of fear, getting overwhelmed with alertness, it heightens the risk that also from the endocrine system, perhaps more likely to be a little bit expressed cortisol. What makes cortisol in my inner perception? Basically, it goes to mood swings, and my irritability is slightly increasing. Of course, many other physiological dynamics will be also here coming up, like eosinophilia is decreasing, and my mucosa production in my stomach is perhaps less, and my acidity is a little bit higher, and so on. I don't want to go in all of it, I just want to give you an idea. And also more top-down than our biological level, our microbiome is really sensitive to emotions. So fear and depression increases the risk, for example, for Staphylococcus aureus, Staphylococcus mutans. These guys are really very specialists, they can do not too much. But one thing they do is also they highly increase a pro-inflammatory phenotype in patients, so it could be interesting if we have pain patients also. Yeah, but also in the metabolic system, it heightens the risk slightly to get a little bit insulin resistance, and many more. I don't want to go to all of this, just to give you an idea. And then, of course, if I feel always the life is not safe, getting fear feelings, it affects possibly, at least, my posture. So like a turtle posture, to be sure, higher, bigger eyes to check everything. And this turtle posture already perhaps has a higher risk for certain sicknesses coming in your clinic. Yeah? Like this, perhaps C0, C1, C2 compression, and so perhaps tension, headache, or shoulder-arm syndrome, pectoralis minor is a little bit more tensed, or chronic gastritis, psoas syndrome, and so on. Okay? And then he comes to your clinic and asks you, let's say, tension headache. You're an osteopath, can you deal with it? Of course, your answer is yes. Yeah, and you are really right osteopath, you know all the important topographic connections, and the patient shows this sign, you know immediately, this is occipital major nerve, comes from C2, so perhaps you manipulate C2, you know it lying on rectus capsus posterior major. You know even myodural bridges, which you could include in your clinical approach to the patient. And you know it runs through the semispinalis capitis, through the trapezius muscle, runs then alongside of the arteria occipital artery. You can even make a slight gliding of the nerves, so in the epineurium and mesoneurium, so the nervi nervorum gets a little bit more calm. And then you know when it when he said, it's like here, you know, anastomosis to supraorbital medial lateral nerve, and you're also dealing with it. But the question in my clinic was, if I do all this osteopathic stuff, does it mean that all the other dynamics disappear? This was my question in my clinic, and I have to give myself the answer, no. At least not probably. It can happen. But first of all, do I have the understanding of the mechanisms of all these terms, which are cortex and limbic system? Second, do I have abilities to diagnose it? And thirdly, how is the interaction of these? I didn't know. So I really need to understand more about it. And of course I use research, even I'm not a researcher, and papers to understand more about what I'm doing in my clinic and perhaps to find inspirations and answers. But further on, the patient doesn't come only with one top-down line, no. I mean, he has top-down, bottom-up lines, and every patient is different. So every patient comes with a specific cocktail of top-down and bottom-up dynamics, which has a big influence on his complaints and on the healing access. And further on, all these dynamics, which probably can happen in a patient in the daily, everyday clinic practice, the question is this all? No, of course not. Why it should change by itself? It only changed because of the context. But how much context we learn to understand the mechanisms of action in influencing the body, beside accidents, of course. This is the specific topic in osteopathic history. Yeah, but there are toxins influencing all this. There are also pathogens, as we just saw, influence strongly all this. We have metabolic stress, we have biochemical stress, we have emotional stress, we have physical stress, social stress, very good research, by the way. And also in a paper from 8 years ago, electromagnetic stress can influence our physiology. So this is important to understand, because if we don't know why this change happened, what we are not dealing with an autistic person doing a little bit chichi and suddenly everything is done. If we understand why and in which interaction the external world, the context, is dealing with the body, then really our understanding in therapeutic accesses is much different and much deeper also. Besides this, also the way we are dealing with the external and internal world by exteroception, proprioception, and interoception is not the same in every patient. It's very different. So again here, if we understand that this is different, we can act differently to each patient. And finally also, it is not suddenly happening, but there's a timeline. Yeah? Evolutionary already, ontogenetically, but the timeline of summation of perhaps risk factors which come then to a certain moment, then the patient complains or shows so-called somatic dysfunctions. And my belief is that if I integrate this kind of understanding, it will change my therapeutic approach. It will change techniques I develop in my daily clinic, and it will change also the kind and the art of palpation I use in a patient. This is my hypothesis, or let's say working model. And I'm dealing with it since now 20 years. And that's not the whole story. Again, there's another thing. And this is, you know, the 5 osteopathic models developed by Greenman, developed by Mitchell, and later on by Ruby. Yeah, it is, we deal with it, and we try to approach our hands on it somehow. But again, it only is changing by these external context factors, changing from homeostasis to allostatic. And mostly all research shows in middle term and long term that there's one thing, and this is that what counts is the proactivity of the patient relating to the context. And my big question was, after all, how much the patient learned this in my clinic? Most of the time I learned that he lays flat, not moving a lot, sometimes muscle energy technique, sometimes I ask him to breathe in, hold the breath for a moment, but mostly that's all. But it's something you have to learn. You don't get it just like this, more proactivity. And the question is really for me, for a long time, how and why we don't use this most important factor to be able to get healthy again and to maintain health, because without proactivity it's not. And what means proactivity? You know, for example, I do yoga a long time. The world record in stop breathing is 11.38 minutes. 11.38 minutes. You need a lot of proactivity to come closely to this number. Yeah? Or even if we decided evolutionary to be a weak species, if I want to be strong, I can lift heavy weight, 492 kilograms. Again, how much intention, how much proactivity you need to achieve this competence. Health is another thing you need to achieve. You really want it. No, you can say, yeah, I think to eat pizza is not so healthy. I run out, get the smell, get a little bit salive. Next minute, what I have in my mouth is the whole pizza somehow disappeared. Yeah, to learn to make these slight changes, it costs so much proactivity. Okay, so why we don't use it was my question. So I started to develop new approaches and technique where also the proactivity of the patient is much more important. Yeah, when today and yesterday we heard osteopathic approach was always dealing with the therapist. The therapist can touch and feel, and how is the attitude of the therapist, and how he can tune in with biomechanics, energetics, or whatever kind of breath of life sometimes. Yeah, but I mean, perhaps it's also important to integrate more proactively the patient, because this changes all. Yeah, you don't learn piano by thinking about nothing and just nearly sleeping. So why we don't ask just a little bit more focus of the patient and treatment process, if all research, by the way, shows it, that it's such an important point. Okay, so it means first perhaps to give him more understanding about the mechanisms of action of health and sickness, to give him a little bit more help and support in integrate his proprioception, his interoception, his exteroception in the treatment process and in his daily life. Because again, if something happened in my treatment room, like a therapeutic uterus, it doesn't mean at all that when he goes home, it stays the same. No? In the treatment room, it's just you play when you learn soccer. There's an empty, how to say, goal, yeah, and you learn to put the ball there inside. But in real life, there are the goalkeeper, there are 3 huge defenders, and it's a total different game to put the ball inside this fucking goal. Yeah, and this is not life. You know, my neighbors and my life friends and whoever I meet during my life is not my mother, so they don't mind about me, they mind about themselves. And to dealing with this constant changes of context, it is my flexibility, my adaptability makes that I stay more healthy. And my really question was, why I don't support this in my clinic? Why I don't ask more proprioceptive focus, interoceptive focus, and exteroceptive focus during my treatment? Okay, so I developed really new techniques regarding also to the needs of the patient, his belief system, integrates his emotions, arousals, and risk factors, so that he can make meaningful decisions. Because you need these competencies to make meaningful decisions in my treatment room, and most important, outside my treatment room. Yeah. Intention, motivation, so that the patient is able to be a little bit more proactive. Proactive means more flexible in his metabolic system, in his psychic functioning, in his biochemistry, in his endocrine system, in his immune system. Yeah. Even that he has a little bit more discipline for changes and perseverance also. Out of it came, by the way, this book Ulrike was mentioning. There I put also top tips, also research. Mostly I use systematic reviews to it. Then I support the patient in all these 5 models and all organs. Okay. And research, again, give me support that my idea, how I deal with the patient, can work. Even new research shows that the context makes, it's an important factor in the treatment. Okay, so it's good to use research as a clinician, even we are not a researcher. Yeah, so we have also the subjective part of a patient, which could be much more integrated, not just that we touch and we believe everything changes in a good way. We can do it a little bit more consciously. You know, the arousal, the representation, the body sensations, the emotions, belief systems in the patient, integrated more in your treatment. And again, science shows it in clinical cases, like for example in sleep bruxism. Yeah, we know, can I have a little bit water? We know that, for example, anxiety and anxiety disorders is associated with sleep bruxism. Clear research. Okay, so also our clinic should and could at least integrate that there is an influence when we treat sleep bruxism. And also, like I told you, where intersubjective influences in the patient, in complaints, in health and in sickness, and in the development of somatic dysfunctions. And also here, yeah, we see that friends and family, for example, is a big influence factor in the development, for example, of sleep bruxism. Separation makes a higher incidence for sleep bruxism, and dysfunctional family constellations also. And also the biosocial world, big players, really, really big players. You know, it's really about lifetime also. I think there was research, 2015 in Nature, 1% of the richest persons and the poorest persons in the States, the time length difference is 14.6 years. Nearly 15 years difference if you have a little bit more money in your pocket. It's not only the hand, there are many other factors we could include, at least give free children clinic for treatment of children, for example. Again, here also it proves, you know, more than half of the children affected by sleep bruxism has a low socioeconomic background. So it's really, it's not just academically, it is touching our daily life. When we deal with, for example, and said, yeah, I'm an osteopath, and we can deal with sleep bruxism, for example. How it has happened that our way, how we work, was different, like I tell you now. It is because of the past. Of course, still lived in a completely different time, social background, history, medical knowledge, and also challenges. Yeah? In that time, challenges was infection diseases. And I read more than 1,000 cases for my PhD, how osteopaths were dealing with patients, and I put out all this anatomic detailed stuff. And there's, I would say, more than 90% a certain line which you can find. It is, you find, or at least the anecdotes, how the old ones treated still and all the other ones, yeah? It is, they found impaired movement in bones, joints, ligaments and muscles, which leaded to stagnation and local blood and lymph fluids, which leaded to irritation of nerves, which leaded finally to disturbance of organ vessels, still named this way often life fluids. This was for him the reason to get sick, the ultimative reason to get sick. Of course, then in current stuff, he added a little bit esoteric and so on. Yeah, but this was the basic line when you put out all the detailed stuff of all the bones and nerves and so on, what was involved. But the reality, again, today is different, and we know it because research papers were published, explain many different influences. Yeah, it is more, and here I put why this happened, what was the contextual influences, but I don't want to go in it. Yeah, nowadays we could know much more in detail how are the influences, and this can inspire our clinic. For example, genetics. And again, as example, I played, yeah, HTR2A gene polymorphism, highest risk to get sleep bruxism. So yeah, there is a genetic component, and why not know it, at least to know that there are this genetic component, because somehow if we know it, we can relate to it. This is the point I want to mention here. Yeah, but beside this, of course, we have transgeneral dynamics. Many research was done about DNA mutilation, telomerase influence, and so on. But we have also prenatal factors. We have perinatal factors. Prenatal factors, very much researched now since many years, but for still it was not possible to know this research. Yeah, about 11-beta-hydroxyureogenase 1, which goes up in acute stresses and deactivates cortisol, but in chronic stresses it doesn't rise even 90%. So this is really important knowledge. Even just asking the parents, did you have some stress, to understand what the baby brings with it when he comes in our clinic, for example. Yeah, but also prenatal factors, it's more insulin conditioning, I don't go into it. Postnatal factors, very good research, early life stress, interculturally, big influences on health. Infectious, of course, accidents, life circumstances, yeah, do I have a partnership or not, do I have friends or not, do I have a job or not, do I like a job, do I earn money with a job, what is my social status, how is my living environment, crazy important factors on health. Yeah, top-down, bottom-up processes, which we saw right now, lifestyle habits, also how I eat, do I move, do I sleep sometimes, get I be touched sometimes, and of course the 5 osteopathic models. Yeah, so there are many influences, and if we understand it again and again to the patient coming to me in the moment to my clinic room, my therapeutic approaches out of these conclusions will be suddenly wider, and my techniques out of it will be also wider. Even what I mean by technique, always as osteopaths using the hands, of course. I give an example from clinic. Yeah? I always try to distinguish between the game, between everything is a whole, but also a part of another whole, and so on. And I got a patient, he was a half marathon runner, and he was confronted with reduced performance and increased sleep bruxism. And so I make all my exam like you do, mostly. And I found, basically, when I came to distinguish the skin and the receptors, I found slightly on the right side, vibration was less perceived than on the left side. So pachylified receptors perhaps were involved. And of course, we know that this dermatome is related to femoral nerve. So I checked the femoral nerve. Oh, and also if there is less cartography in my brain, the brain said danger. So take a little bit more care, protect a little bit more, because you don't know, it's suddenly a little bit more unknown land. If the receptors doesn't work so much, of course your cartography is less functional. Okay, and then I checked the femoral nerve, but it was fine, no problem in the inguinal ligament, but also, I measured the force a little bit. The rectus femoris was slightly diminished, but only slightly, a little bit vastus medialis also, but sartorius and all was okay. But then I measured the extension function. I saw that it was on the right side slightly reduced, so the psoas was reacting. Should I treat now the psoas? Because also the nerve goes through. It could be, but the psoas could be also part, like in this patient, part of the digestive system. So on the psoas we have the nice cecum and colon ascendens, and really it was extremely pain sensitive. Yeah, so should I treat now the cecum? Could be. Yeah, but also why it is pain sensitive could be a question. In this case I make a laboratory of a stool analysis, and the alpha-1 antitrypsin was really high, so inflammation in the digestive system was going on. And also the microbiome changed slightly, so Akkermansia was really low Yeah, should I treat now the microbiome as an osteopath? I don't know. I don't believe that I have such an influence on it, but still. Yeah. So I asked about nutrition. He said, no, I eat really good. I take care of my food, and he explained me everything. Only since 6 months, I starting in the evening to drink half bottle of wine and 2 bars of chocolate. Yeah. So I asked, you only do it in the evening? Because if he does it every day, it could be leptin resistance, insulin resistance. But he said, no, only in the evening. I said, oh wow. Yeah, it's more guiding me to emotional neediness in the evening, because when all the context factors goes down in the evening, the inner, how to say, restlessness comes up. I know this when I'm teaching alone in a hotel bar. I have this also in a hotel bar, not outside. You know, and the bad thing is then in my hotel room where there's this nice mini box bar, and I open it to try to calm me down. Suddenly it's empty. And I called the hotel and said it was empty. I mean, it's not nice. They should fill it up. So this kind of things, okay? And it's also good research, by the way. And he said, yes, 6 months ago, his partner left him. But again, here, to understand, could be interesting that if you really eat a lot of chocolate just before going to bed, drink half bottle of wine, it could influence your reflux. And here research shows also the prevalence for sleep bruxism is 74%. Yeah, he had slightly sleep bruxism before, but since 3 months it was really increasing. So again here, what I treat and how I treat, if I just go to C2, manipulate C2 and say, yeah, that's all, or C1, because I know this is, or make a little bit, is it really what he needs? Could I give more as an osteopath? Or different approaches integrated? I would say yes, from today, at least. Yeah. And then there's another thing, I told you already, there's evolutionary older things and newer things, and the semicircle ducts is newer, and macular organs is older, is more fundamental. Yeah? In his case, the utriculus was not so functioning well, so his way in speeding up could influence all of this. By integrating all this, I personally, even it's totally speculative, extremely subjective, biased by my neurotic brain, I think if I integrate it and color it by objective tests, I could have a deeper flexibility in relation to a patient when I integrate this kind of reasoning, clinical reasoning. And of course, then there's phylogenetics, epigenetics, there's disposition, morphodynamic factors or risk factors working over time. All this is a big factors to understanding patients' somatic dysfunctions and complaints. Yeah. I go over this. And again, sleep bruxism also, I use it as an example here, is related to stress and post-traumatic stress disorder. And here another question coming up, and the question here is that imbalances by multiple risk factors are, by multiple holarchic organized regular dynamics, maintained actively. First, functionally, but over time, it could be even anatomically. Yeah? If you have a lot of stress, there's a change, possibly, for example, in glucocorticoid receptors, because they rebuild after 6 to 8 weeks, but they get less active and then less rebuild if you are exposed to chronic stress. But if you have already an anatomic change in less amount of glucocorticoid receptors, then of course the measurement in the hypothalamus and in the hippocampus is much less related to cortisol. So this is really important, because also here again, you know that your prognostic of treatment need to be much longer, because it just doesn't appear because you do a little bit myofascial release techniques. It needs a longer approach, and you have to consider this in your treatment plan you discuss also with the patient. So the differentiation of functional changes or more structured. Oh, this looks a little bit messed up. Yeah? And then it gets maintained by psychic, by sensomotor, by collective coagulation. Collective coagulation could be something like pizza service. In former days we had to run 2 hours. Nowadays to eat food we just call pizza please, double cheese, 3 salamis, and then the movement of my arm would be just open the door and then eat the pizza. Completely different dynamics in the reasoning if a patient gets perhaps pain syndromes also. So, what it means for my clinic, we can play all these games in palpation, which is cool, which is a really cool competence, but we added a little bit. We added with be competent in also perceiving facial expressions, gestures, posture, movement, breathing, pulse, heart rate variability, pupil size, sweat, temperature, and many of this you can even ask the patient to be proactive with. And also by adding more context of a so-called somatophysiological experience dysfunction, I would call, because the experience is for me now an integral part in the treatment. And this doesn't mean that I integrate it and the patient stays passive. No, he's extremely active, much more active, putting focus in different areas when I treat them. And we do also research, not me, I'm not a researcher, but others, to show if my approaches and techniques work. And somehow our first 3 papers, are not papers, still before papers, show that it worked for tension headache, for stress, chronic stress, and so on. Of course, we need to go on to see if it really works. If not, I forget it. But perhaps it worked, yeah? So also we can integrate more extraception, more proprioception, more interoception of the patient actively in the treatment process and after in daily life to know better what is good for him or her and what is perhaps not so good for him or her, and to correlate him or himself better. Arousal and feelings and cognition and mentalization. And basically this could mean my final paper, my final picture is that even when we palpate, we can use palpation and integrate in our palpation negative and positive emotions actively of the patient. I can even ask my patient, never I was taught this, where do you like to put my hands? Osteopaths always, I never learned this, that I know better than the patient where to put my hands. But now I do very often, I ask the patient, where do you want that I put my hand? Or I integrate it. I tell them, what is your strongest not solution, everyday ongoing stress, and where you feel it in the body? I feel it here. Okay, interesting. Yeah. Perhaps, do you want that I put my hands here? Yeah, why not? I integrate the eye movement related to it. And suddenly, by changing also with palpation, of course, proprioception, interoception, with my palpation competence, I help for the processing of this situation. So put it in relation to negative or positive emotions, to hypo and hyperarousal, to resources and triggers in the patient, to allow a flowing state in the processing afterwards, and being attentive, of course, to physiological reactions during the palpation process. And actively use sometimes also your mouth. What's going on? Yeah, why we expect that we can feel everything with our hands? It's nice to ask sometimes. I was surprised, but I felt completely different than what the patient was saying, by the way. And support patients in perception of these reactions. Don't let him sleep. I mean, if he's so catabolic in his life, it's good that he sleeps. But I mean, it's also cool to invite him to take part in the treatment process, yeah, and support in all ways his proactivity. This is what I do now, much more. And I wanted to share it with you, so thank you very much.